Let's talk a little bit about keratoconus and the confusion surrounding how to treat keratoconus, because there's such poor information out there about how to treat keratoconus. A lot of doctors simply don't have a lot of information that's out there for more advanced treatments, and the patients are just left trying to figure out who's telling me what, who's telling me this, who's telling me that, what does it all mean? And so keratoconus causes major problems because really the cornea degenerates into a cone. It's being pushed out at a weak point in the cornea by the pressure inside the eye. It's being pushed out in a direction like this, and each person's cone that's being formed is different because it's a combination of the genetic weakness of where it is in that cornea. It's a combination of the pressure in the eye, how long it's been going, and yes, even as people talk about eye rubbing, if you have a weakened area and you keep rubbing it, it's gonna make it worse, okay? Essentially, what you have to look at with this is, how do you fix this cornea that is now really kind of a strange shape and variable in every single patient, because each one has its own conditions that it degenerated in and its own conditions of the time of length that it degenerated. And so there's been a series of procedures over the years. Of course, there's corneal cross-linking. Corneal cross-linking simply makes a procedure or makes more bonds within the corneal cells and causes it to stop progressing. It'll cause a little bit of flattening and a little bit of refractive change, but it's not going to help the vision a ton. If you're going to use corneal cross-linking and simple glasses don't work because your cornea is too irregular, or soft contacts don't work for the vision because your vision, cornea is too regular, then you have to still use scleral lenses. Then there are patients who actually turn to procedures that try to make the corneal shape better for better vision. And there are specific procedures and kind of more non-specific procedures, and some try to bridge the gap. The original procedure many, many years ago was to put small plastic inserts or circular type rings or semicircular type rings into the cornea to push that cone back down, okay? And so, as you can imagine, sounds like a good idea. The problem is it's not specific to that cone and to that shape. So when you put that in, you're pushing down, and hopefully you get a better shape, but really how much better does it get? It may not get a lot better because it may still be too irregular through that central cornea. There's been variations and modifications of it, like CTAK, which essentially tries to customize the procedure further by, instead of using plastic or these type of plastic strips, they use corneal tissue. And then that's modeled a little bit more appropriately to the patient and where it's put in and the amount of corneal tissue and the strip to try to get a little bit better result. But again, this is a macro way. You're pushing this cone down. You're not mapping it. You're not sitting there directly addressing micron by micron exactly that shape. So it can help. It can make things better, but it's not making a more normal cornea really per se by mapping it and changing it. Then there's the procedures of people trying to do specialized corneal cross-linking that seem to somehow decrease the actual irregularity some more. These are yet not completely proven. They're interesting, not completely sure where this is gonna head. That's one of those stay tuned. The only real way we have of actually reshaping that cornea to try to make it really more normal is to actually map it and then use a laser system to whittle down the high spots, fix and raise the low spots, which we can do to try to make a more normal corneal shape. This is topography guided ablation, and it's been around for many, many years, and originally was actually started by a doctor in Greece in the 2000s. The system was invented over 20 years ago by Theo Seiler of Germany and Switzerland. And then what happens is that we map the cornea and essentially micron by micron change the shape of it with the laser. This, of course, requires that there's enough tissue present. But it turns out in probably the vast majority of keratoconus people that come here, there is enough tissue present to do the procedure, make a more normal cornea, even for very severe cases. We see a lot of very severe cases, not mild cases here. And you know, we are able to then do that, and then we cross-link right there to freeze that. And so a lot of these patients end up with significantly better vision, not only an improvement in vision, but improvement in visual quality where it feels much, much more normal. So it's a little bit more precise. Well, it's a lot more precise than using a suspension type procedure where you're really pushing that cornea back down. And there are ways to increase these topography guided procedures where we can then do trans PRK approach, where it actually goes after the part of the irregularity that is compensated for by the epithelium and therefore masked to the systems measuring, the topography systems. It turns out that's about a quarter of the irregularity on average is what we found. So that's fairly significant. And let me say that if you're just doing a regular PRK for correction or a wavefront guided, that is not the same thing as a topography guided procedure. That is actually not going to change the shape of the cornea, just treat the actual refractive error. And there are some people that have tried that and some people that still keep trying to do that when really it is not as helpful as reconstructing the cornea. These are the basic ways which we can help keratoconus. Fortunately, the state of procedures has gotten so much better that there's a lot of hope for keratoconus patients. The downside is, of course, a lot of this is not insurance covered, which is a shame, and it should be, although some patients are getting quite a bit of reimbursement. For example, our procedures, which has at least been a real improvement where a few years ago they were getting nothing. But it is something where it can really provide hope to a lot of keratoconus patients.